Clubfoot deformity. Congenital Talipes Equinovarus. Clubfoot, or congenital Talipes Equinovarus, is a common congenital deformity affecting approximately 1 to 2 in 1,000 births. The components include forefoot adductus, hindfoot varus, and ankle equinus. Anatomy of clubfoot. The talus is smaller in clubfoot than a normal foot and has a flattened superior surface with consequent decreases in talocalcaneal angle. The subtalar joint facets are misshapen, and the navicular is oriented more downward and medial than in the normal foot. Deformities of the tarsal bones are considered to be the primary cause, while ligament and joint capsule changes adjust to the distorted position. The ligaments are generally thickened and muscles are hypoplastic, resulting in generalized hypoplasia of the limb with shortening of the foot and smallness of the calf. The foot appears smaller as the result of a flexible, softer heel caused by the hypoplastic calcaneus. Ankle valgus may evolve with growth and may be mistaken for overcorrected clubfoot or hindfoot valgus. Severe cases of metatarsus adductus may be confused with this, but the equinus component differentiates the diagnosis. Abnormalities in conjunction with idiopathic clubfoot. Other musculoskeletal abnormalities commonly occur in conjunction with idiopathic clubfoot. Tibial shortening, ITT, or decreased external tibial torsion, and increased internal hip rotation. These changes may not be significant in some because the external tibial torsion may increase with age and the internal hip rotation may decrease with age. Also, a factor may be the manipulation technique used to correct clubfoot. External tibial torsion increases if the corrective technique does not allow a progressive eversion of the talus underneath the calcaneus. Therefore, rotational malalignment should be examined and monitored, although operative correction generally is not recommended until after 7 years of age because alignment may spontaneously correct with growth. Genetic cause of clubfoot. The cause of clubfoot is considered to be a combination of genetic and environmental factors. A genetic influence is suggested because siblings have up to 30 times the risk of developing clubfoot deformity and monozygotic twins have a 33% concordance rate. Also, a male predominance, 2-to-1 ratio, is present, although affected females are more likely to pass on the trait to their children and have siblings with clubfoot than males. Higher incidence is also seen in Hispanics and a lower incidence in Asians. Environmental cause of clubfoot. Environmental factors have also been identified. These include factors during pregnancy such as cigarette smoking, early amniocentesis, or viral infection. Cases of clubfoot related to intrauterine positioning are generally mild and correct rapidly with intervention. More severe cases are thought to be from factors occurring earlier in fetal life, while idiopathic cases are generally in the middle range of the severity spectrum. Intervention for extrinsic clubfoot deformity. Extrinsic clubfoot, severe positional or soft tissue deformity that is supple, can often be successfully corrected with conservative interventions such as serial casting, which should be started as soon after birth as possible, although some have used up to 9 years of age. Ponseti method. Ponseti in the method used to correct clubfoot through serial casting. Casts are changed in the Ponseti method semi-weekly or weekly. Foot should be positioned so that it can be corrected in an orderly sequence by first correcting the cavus, rotating the foot from under the talus, and finally correcting the equinus. 20 after 4 to 6 castings. Many may require an Achilles tenotomy to lengthen the tendon. Most can change to a brace for 3 months at that time, followed by a sleep brace for 2 to 4 years. This method is considered the standard approach throughout the world. French method for extrinsic clubfoot. A second method, the French method, involves daily manipulations of the foot by a therapist, stimulation of the muscles around the foot, and temporary immobilization of the foot with plaster cast. Duration of the intervention is generally 2 months and has been found to be effective in varying stages of severity. Some may require a tibialis anterior tendon transfer, usually between 3 and 5 years of age, to control dynamic forefoot supination or recurrent deformity. This is considered to be a minor procedure as it does not affect the joints of the foot. Intervention for intrinsic clubfoot deformity. Surgical techniques are used in cases of intrinsic, rigid, clubfoot. Surgical techniques includes manual reduction lengthening of the Achilles and posterior tibiotalar and taloalcaneal capsulotomy to correct equinus, posteromedial talocalcaneal capsulotomy and or subtalar release to correct hindfoot for midfoot adduction, and plantar fascia release for psoas varus, release of the abductor hallucis and talonavicular joint deformity. Thanks for watching. Subscribe to Medico Tactics for more such videos.